Welcome everyone to my presentation about the Schillings Test.
Before we start, please note that some of the articles used throughout this assignment is older than 10 years. This is due to the Schillings Test not being a common examination anymore and not much data is being published about it. These articles are still relevant as they are referenced in the 2021 StatPearl guidelines.
The main objective of this assignment is to describe and explain the Schillings Test. Okay, let's jump in. The Schillings Test is named after Dr. Robert F. Schilling. It is a diagnostic examination used to determine whether or not a patient has adequately been absorbing vitamin B12, aka cobalamin, or not. In order to perform the study, an oral dose of radio-labeled vitamin B is given to the patient in the form of a capsule, and then the urine is collected over the next 24 hours and then measured for the vitamin B level. Why is this test performed, you ask? This test is useful to evaluate for the production of the intrinsic factor within the stomach. The intrinsic factor is a type of protein that is responsible for the absorption of vitamin B12, and without this intrinsic factor, the body cannot absorb vitamin B12 adequately, leading to things like pernicious anemia. Basically, this test has the ability to demonstrate impaired vitamin B12 absorption, and it is also used to determine other reasons for malabsorption of vitamin B12. The test is significant as it is used to confirm vitamin B12 deficiency and establish the underlying cause thereof. It can also distinguish between pernicious anemia, transport failure, and ileal uptake deficiency. The principle on which this examination functions is based on the fact that vitamin B12 or cobalamin is a cobalt-containing compound that is synthesized by bacteria. When vitamin B12 is ingested orally, it binds primarily to the R protein. The R protein is responsible for protecting the vitamin B12 against stomach acid and is cleaved from the vitamin B12 in the duodenum through binding with the pancreatic protease and the intrinsic factor. This intrinsic factor is responsible for the absorption of vitamin B12 via the Q-in receptor within the terminal ileum. Thus, a defect in R binder, intrinsic factor, or within the terminal ileum may result in a vitamin B12 deficiency. Non-radioactive vitamin B12 saturates receptor sites so that only the oral radioactive B12 is absorbed and excreted in the urine. The urine is then collected, measured, counted, and compared to a standard in order to calculate the percentage of absorbed vitamin B12. Low absorption is strongly suggestive of malabsorption of vitamin B12 within the gastrointestinal tract. As for the clinical condition, the normal nutritional requirements for vitamin B12 is 1 microgram per day, and the average diet usually contains around 2 to 30 micrograms. Deficiency in vitamin B12 can manifest over a long period of time as it is stored for up to 800 days in the body. Vitamin B12 is naturally absorbed from meat and dairy products and is bound by the intrinsic factor in the gastric mucosa and is a coenzyme needed along with folic acid in vegetables for the DNA synthesis and cell division in bone marrow. It is also responsible to produce and mature red blood cells. Neurological changes are often associated with severe vitamin B12 and folate deficiencies and may not be reversible. Deficiencies in vitamin B12 can be caused by a lack of intrinsic factor due to pernicious anemia, gastrectomy, dietary lack of the vitamin, bacterial overgrowth in the bowel, the inability to absorb the intrinsic factor and B12 vitamin complex in the terminal ileum, resection of the bowel, and disease states such as Crohn's disease. And when we move over to indications and contraindications, we can see indications include the diagnosis of pernicious anemia, diagnosis of macrocystic or megaloblastic anemia, evaluation of gastrointestinal absorption of vitamin B12, evaluation of small bowel malabsorption of vitamin B12, evaluation of thrombocytopenia or leukopenia, may also be done when bacterial overgrowth syndrome is suspected or if ileal dysfunction is suspected. The contraindications include pregnant or lactating women and patients that cannot consent to the procedure. In order to do the examination, the radionuclide cobalt-57 is used. Cobalt-57 has a characteristic half-life of 270 days, 122 kiloelectron-volt energy emissions, and decays via electron capture and gamma-ray emissions. It is also produced within an accelerator. The radiopharmaceutical of choice is cobalt-57 cyanocobalamin in capsule form. This is usually provided from the radiopharmacy in a kit and contains a dose of 0.3 to 1 microcuries. This radiopharmaceutical is chosen due to its method of localization, as it also binds to plasma proteins such as the intrinsic factor. After it is being bound to the intrinsic factor in the gastric mucosa, it is absorbed into the bloodstream via the terminal ileum and stored in the liver as per normal physiology for vitamin B12 absorption. The method for administration is oral or per os for the evaluation of the intrinsic factor. Some factors that may interfere with the test include patients with acute illnesses leading to nausea, diarrhea, or vomiting, as this lowers the level of vitamin B12 available for absorption, and the results will thus be suboptimal. When we look at the equipment needed, you will need a urine container to collect the 24 to 48 hour urine sample, vials to place the urine samples in for measuring, pipettes for measuring precise sample sizes and placing it within the vials without spillage, labels for labeling the vials and the containers. The detectors will include a well counter or any other gamma counter such as a gamma probe. The only thing is it must have a 4 to 20 channel setup with an onboard computer, and then the computer setup should be set to an energy window of 114 to 144 kilo-electron volts. As for patient preparation, always identify your patient and verify the doctor's orders. Explain the procedure to the patient and clarify any questions that they may have. Instruct the patient to be NPO from midnight before the test, or at the very least only 4 hours before the test, and continue to be NPO for 2 hours after ingesting the radio tracer. Instruct the patient to withhold all parenteral vitamin B12 for 3 or more days prior to the test. Instruct the patient to collect all the urine in the provided container over the 24-hour period. Instruct the patient to drink only water exclusively for the 24-hour period, and then instruct the patient to have no other tests, enemas, or take laxatives during the duration of this test. Compile a complete and relevant history indicating medication of the patient and history of anemia or any allergies relevant. As for the procedure itself, here is a sample protocol. This procedure is estimated to take about 30 minutes. But before dosing your patient, get the kit from the radio pharmacy and assay the patient dose and record this, as you need to know the exact dose given to the patient. Also assay your standard dose and record this as well. Label your paperwork, your collection containers, your vials, and your doses accordingly. Note that it is important to collect a pre-dose urine sample. This is required when the radiopharmacy indicates a background test tube or if the patient has had a recent nuclear medicine study. The Schillings test is divided into 4 stages and a dual isotope study. So stage 1 is performed without the intrinsic factor. The patient must be fasting, so control to ensure your patient is fasting. Instruct the patient then to empty the bladder and collect your pre-dosing urine sample. Instruct the patient then to ingest the radioactive capsule and note the time of administration on the paperwork. The patient should then be given the 24-hour urine collection container and start collecting immediately. Ensure the patient is still fasting for at least 2 hours after ingestion. Then instruct the patient to return in 1 to 2 hours for the intramuscular flush dose of 1,000 micrograms of cold vitamin B or unlabeled vitamin B, which then saturates the remaining vitamin B binding sites in the body so that whatever labeled vitamin B was absorbed in the intestines is then excreted into the urine. Then instruct the patient to return in 24 hours' time with the collection containers and record the total amount of urine that the patient brings back. If the findings in stage 1 are normal, then there's no further investigation needed. Sometimes it may be necessary to collect urine over 48 hours, and this is if your patient's serum creatinine level is more than 2.5 milligrams per deciliter. If the results are abnormal, then stage 2 is indicated and should be performed within 3 to 7 days after stage 1. Stage 2 is then performed with the intrinsic factor, so the patient should be instructed to return within 3 to 7 days. The same test is then repeated on the patient after the patient has received a capsule containing the intrinsic factor, about 30 milligrams, along with the 57 cobalt labeled vitamin B12 capsule. If the findings in this stage is normal, that indicates that the patient has a lack of intrinsic factor and is most likely a diagnosis for pernicious anemia. If the results are abnormal, then stage 3 is indicated. Stage 3 is then performed after an antibiotic treatment is given to the patient. This test is done to see if there's any abnormal growth of bacteria causing the low vitamin B12 levels. A physician will thus prescribe an antibiotic treatment to the patient, and the patient should return within 5 days after starting the antibiotic treatment. The same test is then repeated as in stage 1. Thus, if the results are normal, it indicates that there is bacterial overgrowth causing the vitamin B12 deficiency, but if the results are abnormal, stage 4 is indicated. Stage 4 is the pancreatic vitamin B12 stage. This is performed to rule out any issues relating to the pancreas. A 3-day course of pancreatic enzymes is given to the patient, followed by the administration of the radio-labeled dose of vitamin B12. A urine sample is then collected over 24 hours and is done in the same manner as stage 1. Thus, if the findings are normal in stage 1, this is indicative of pancreatic enzyme deficiency. Schillings test may also be performed as a dual isotope study, and this is achieved through the usage of cobalt-57 and cobalt-58. The characteristics of cobalt-58 include a 72-day half-life, 810 kilo-electron-volt energies, and decays via electron capture and gamma-ray emissions, and is also produced within an accelerator. The dual isotope study is then performed through administering cobalt-57 labeled vitamin B into an egg yolk of about 50 grams and then serving it with toast and coffee as breakfast, or it can be given in a capsule form but without the intrinsic factor. And then cobalt-58 labeled vitamin B with intrinsic factor is then given simultaneously as indicated by the radiopharmacy kit form. A flush then is then administered intramuscularly as in Schillings stage 1. Urine is then collected over the next 24 to 48 hours, and it should be counted by using 2 standards and 2 windows. The counting procedure and results are the same as the previous tests. It's all just performed within one step. As for measuring and processing of data, ensure that the lot numbers are correct and record the total amount of urine received from the patient. Measuring of the samples will include pipetting 2 patient samples of 4 ml each into separate test tubes. Then place the standard also into a test tube and pipette water in to make the volume 4 milliliters. Typically 0.5 ml of this should be radio-labeled vitamin B12 and 3.5 ml of this should be water, as according to your kit insert. Then count the samples using a program provided by the probe or by the well counter. Count the samples for the same amount of time, usually about 5 minutes, but you can count it up to 10 minutes just to avoid any statistical interference, and just note that all samples should be counted for the same time. In order to perform the manual calculations, one would first need to calculate the net standard counts, the corrected patient counts for sample 1 and 2, and then the net corrected patient sample counts, which will be a combination from sample 1 and sample 2. This slide indicates how these are calculated. After you've calculated your values, you can now calculate the percentage of radio-labeled vitamin B12 excreted in the urine. The easiest method is the net corrected patient sample counts times the total urine volume received over the net standard counts times 4, then times this answer by 100 to get your percentage. Or it can be calculated by using counts per milliliter. Just remember to divide this by 4 since the sample sizes was 4 ml. You would take the patient urine counts over the milliliters it was in times the total urine volume, and then divide this by the diluted standard counts per milliliter and the dilution factor, then times this by 100 to get your percentage of excreted radio-labeled vitamin B12. The dilution factor is calculated as follows. If 4 ml of diluted standard contains 1% of the standard, this should be checked against your package insert, as this may differ from kit to kit, but then this means that 1 ml will contain 0.25% of the standard. Thus, your dilution factor will be 400. When reviewing the results, one should know that more equal to 7% of the dose excreted into the urine at 24 hours is normal, and some places might even use up to 10%. Abnormal results in stage 1 will be less than 7% excreted into the urine at 24 hours, which indicates a deficiency in absorption due to intrinsic factor or intestinal deficiencies. In stage 2, abnormal results will be more or less equal to 7% of the dose excreted into the urine, as this will indicate malabsorption due to an intrinsic factor deficiency. But overall, less than 7% excretion indicates malabsorption due to intestinal illness. As for interventions, intrinsic factor is the only intervention that can be given as a diagnostic tool for pernicious anemia. When we look at the pitfalls, it is important to collect all of the urine over the 24-hour period, as missing urine can cause falsely low results. Obtain a good patient history, including medications, vitamin supplements, and recent food intakes, as that can also influence your results. Impaired renal function may also have an impact, as urinary retention can affect the amount excreted in 24 hours' time. Thus, the collection period should be extended to 48 hours. In conclusion, the Schillings test has become quite uncommon practice in the modern day due to many factors, such as the lack of availability of human intrinsic factor and it being replaced by laboratory tests such as the serum cobalamin test and many more. but no replacement test can provide the exact same information as the Schillings test can, thus it might still become relevant in cases where the exact cause of the deficiency needs to be determined or when the laboratory tests are unavailable. These are my references. Thank you.